Let's take a few more questions. Which of the following actions should have priority to best ensure that the patient will not fall while being transferred to the chair using a transfer belt? We have skid-resistant shoes, staying on the side of the bed with legs dangling for several minutes, apply transfer belt while not impairing breathing, or position the chair so that the move will be toward the patient's stronger side. Wow. All of these are good things to do, right? But it looks like the only one that has to do with a transfer belt is number 3. So, let's see. Oh, I was wrong. So the risk of falling will be most greatly affected by having the patient dangle in order to minimize the risk of dizziness. That was a really tough question. Although these others, it says, were appropriate, the options are not best because they fail to address the major fall concern. Okay. So let's look at proper body mechanics, and this is more related to the nurse. So maintaining a wide base of support, usually you're going to say feet shoulder width apart is how we do that, bending at the knees and hips rather than the back, stand in front of the object, adjust the working level to the level of comfort. I'm notoriously bad about remembering to adjust the bed to my height. And then carry objects, if you have to carry objects, carry them close to the midline of the body. This is just a figure from your book showing what we mean when we're talking about center of gravity. That's your core, and this is showing the wide base of support. If you have to pick up something, this is, see how this person never really bends at the waist. All of the bending is at the hips and the legs. So moving on, let's talk about patient positions now. Each of these positions is discussed in detail starting on page 163, and it goes for several pages. So I'll just talk about, instead of telling you how to do it, because you can read that in the book, what we use some of these for. And your book gives you some. So the dorsal lying horizontally on the back. This is the way that we want somebody to sleep. And the reason nurses are really bad about wanting to put everybody in this Fowler's or semi-Fowler's condition all the time. And Fowler's is great, especially if they're eating a meal in bed or watching television or reading. But if they're not doing any of those things, if they're just sleeping, we need to try to get somebody into this more dorsal or dorsal recumbent position. And the reason is they're going to spend so much time in Fowler's anyway, watching TV or eating, that every time they're in a Fowler's position, it puts a lot of pressure on their buttocks. And so anytime we can get them to lie completely flat, even if we just have a little pillow under their head, that's going to spread out the weight and relieve some of the pressure from those buttocks. So dorsal is just lying horizontally on the back. Dorsal recumbent is the supine position with patient on the back, lying on the back, heads, shoulders, and extremities moderately flexed. And the legs may be extended. So this would be with a pillow and maybe some pillows under the legs and stuff. Fowler's, I've already talked about. That's the position that patients usually want to be in if they're awake so that they can read or watch TV or eat or whatever it is that they're doing. Semi-Fowler's is just a little bit less head elevation. That's that 30 degree. Now, there's some patients, if they have any kind of breathing problems, like if they have COPD, they just absolutely cannot tolerate lying flat, and that's okay. We tried, and the best we can do is maybe a semi-Fowler's. But if the patient can tolerate lying flat, we need to allow them to do so most of the night while they're sleeping. The semi-Fowler's, great for helping them breathe or allowing them to read a book or something, but again, it's going to put extra pressure on the buttocks, and so we want to avoid it when we can. Orthopnic, sitting up in bed at a 90-degree angle, and sometimes it's called a tripod position. And if you look at that picture, the patient has his elbows on the little table. This is the position that is assumed a lot of times by patients that are having a lot of difficulty breathing, because the tripod position is the best way to let the chest open up. And so when you see a patient sitting in this pose, a lot of the time it's because they're having a lot of trouble breathing. Sims position is the position we're going to use if we have to give somebody an enema or a suppository, lying on the side with the knee and thigh drawn upward towards the chest. I think your book specifies which side to go on for the, yeah, it does. The left Sims position. We put people on their left side if we're going to give a suppository or an enema, and that's usually better just because of the way that the large intestine curves. Prone. We don't use prone a lot because, again, it's going to cause people to have some trouble breathing, but I was just teaching amputations in my Med-Surg 1 class, and we talked about using the prone position when somebody has an amputation. It's actually encouraged to do that 3 or 4 times a day. And the reason is, and if you look at the picture, you see how her hip is fully extended. When someone's in semi-Fowler's, Fowler's, or wheelchair all day long, we can cause that hip to become contracted, meaning it's permanently bent and you can't straighten it out. So putting someone in the prone position allows that hip to fully extend and kind of stretch out. And so that's where we would use that if someone was in danger of getting contractures on their hips. Knee chest would basically just be for procedure in a doctor's office, like some type of prostate exam. I've never used a knee chest position for a patient before, although babies tend to like to sleep that way, I've noticed. Lithotomy is the position that we use when a woman has to have her gynecological checks, and we also would use that if we were going to put in a Foley catheter. And I think sometimes they use that for giving birth, although they'll raise the head of the bed up a little bit. Trendelenburg is the head, I call this bat position. It's where they're flat, but the head of the bed goes down lower than the foot. And I used this position quite a bit when I worked med-surg, although you probably won't. Anytime a doctor puts a triple lumen catheter in somebody, we always put them in Trendelenburg. They don't do that a lot in the places that we go to, but when I worked at Deaconess, we had to assist the doctors a lot to put those. They would just do them at the bedside. It wasn't considered a procedure or anything where the patient had to leave the room. But we always had to put them in this Trendelenburg position, and I guess it's to cause the blood to kind of try to pool up around the neck or chest where they were trying to put that triple lumen in. Another way that we sometimes use Trendelenburg is when we have to pull somebody up in bed. That way we can let gravity be our friend. Okay, it's review and summarize time. So we've been talking about mobility versus immobility. We've defined what mobility is, and we've talked about all the purposes it serves. Some of the things we didn't mention: expressing emotion, self-defense, basic needs, recreational activities. I focused on this ADLs and maintaining the body's normal physiological activities. Immobility, there's a lot of complications associated with that. We talked about muscle and bone atrophy. Contractures, that's when a joint gets stuck in place. Pressure ulcers, especially on the buttocks where when someone's sitting for long periods of time. Constipation, urinary tract infection, that can happen because of urinary stasis. Our bodies are designed, our GI tract and our urinary tract are designed to be in motion a lot, and so immobility wreaks havoc on those systems. Disuse osteoporosis, meaning your bones will get weak. You can develop kidney stones from that urinary stasis again. Pneumonia, your lungs aren't able to expand and move secretions like they normally would. Postural hypotension, we talked a lot about that. That's when someone stands up to walk and they faint. That's why we do the vital signs. Anorexia, which just means loss of appetite. Insomnia, difficulty sleeping. Asthenia is just a really fancy word for loss of energy, loss of strength. And then disorientation, when somebody's not up and about doing things for themselves, solving little problems like where does the toothbrush go when I'm done with it. Those type of things can lead to what I would call mind asthenia, meaning when you don't use your mind, you lose it. When we were talking about joints, we talked about contractures, and here is a hand roll. That's just usually a wash rag or a small towel rolled up, and see how this is going to prevent that hand from forming a fist and sticking that way. So that's one way that we can prevent hand contractures. Range of motion, we went over that, and it's in your book. There was a really good, I liked the diagram in your book that went through each, that starts with the neck, goes through the arms, wrist, and then the lower body, how you would do range of motion. And of course, if the patient can do it themselves, you're just going to instruct them, turn your head this way. Usually we use a lot of demonstration and have them return demonstrate on range of motion, but if they can't, if they have paralysis or something, then we would do what's called passive range of motion, meaning it's passive on their part. And so active range of motion, they do it themselves with either completely independently or with some cueing from us. Passive range of motion, we do it for them. The physical therapy department sometimes does it, but they are limited on how often they see the patient, so it's up to nursing to fill in the gaps there. This is a little interesting little note right here. The total amount of activity required to prevent physical disuse syndrome is only about 2 hours for every 24-hour period. So that's why doctors order things the way that they do, up 3 times a day ambulating in the hall. It normally takes about 30 minutes to get someone up, ambulating and then back to bed. So there's 1.5 hours right there. And so if we can just get our patients up and about for even just 2 hours a day, that's 1 hour per 12-hour shift, then we can go a long ways towards preventing a lot of the problems of immobility. Here's a nurse performing the passive range of motion. Again, remember that your hands go on the proximal and the distal sides of the joint. So we're talking about the knee joint right here. So she has this hand proximal to it, this hand distal, supporting the leg in both places. We talked about moving the patient, and basically if the patient can't help at all, we probably don't need to be moving them with people. That's where your hydraulic lifts come in, especially for getting them out of bed. It's just too difficult on the patient and too difficult on the workers to try to get people up when they can't assist at all. When they can assist, we have other tools, rollerboard, gurney lift I didn't really talk about, but these are tools that we use to assist us with patients that can partially weight bear, can stand with just some assist, and can ambulate maybe with just an unsteady gait. But if you have someone who's just dead weight and can't help at all, you're going to need to use the lift. There's just not a safe way to transfer that person. Here's an example of someone that can help. This patient can use the trapeze bar, so we don't have to get the lift to push her up in bed because she's taking most of the effort on herself. And so this is a perfectly acceptable way to help this patient move up in the bed because she's able to help so much. But again, if this is dead weight, if it's a very small person, you can get a few people to help you, and we can use a draw sheet and pull them up in bed. But if it's a heavy person, no, we don't even do that. We use the lift to pull heavy people up in the bed. I like this idea, lift twice, once mentally and then once physically. That way you'll make sure that you have any equipment you need gathered and maybe address some problems before they occur. A lot of the NCLEX type questions that we answered had to do with this step right here, assessing the patient's ability to assist. That's always the first step in moving somebody. Even before you get assistance or before you get equipment, you need to know, is this patient able to help, and if so, how much? We talked about pre-medicating with pain medicine, in that we can do that. It's called anticipatory pain. Even if the patient rates their pain at a 1 or 2 right now, if we're pretty sure that they're going to be hurting because we're going to get them up and walk them on the freshly broken hip, then we pre-medicate for that so that they're not discouraged from doing activity because of pain. I think you've been practicing this in Skills Lab, at least I hope you have. And I wish we had a hydraulic lift in the lab, but we don't. So when you get into clinicals, make sure you ask your clinical instructor if you don't know how to use a lift, or if you've never used a lift. We can give you the opportunity to do that. That's it. I want you to complete your workbooks for this chapter. I'll give you, I don't know how much time there is, but 30, 45 minutes. And then I've made a quiz, and the quiz is just cut and pasted questions from the workbook. Not all of them, but I picked probably about 15, 20 questions directly from your workbook that you'll take on a Scantron quiz. So make sure while you're doing your workbook that you're studying the answers as well. Thanks, bye.